On episode 9 of Healthcare Uncut today, I was joined by Michael Patton, CEO and founder of Excel Health Plans. Excel has a completely different approach to the market where they can save employer groups about 20% premium. They can shift a lot of the cost over so that the insurance company, picks up the tab for patients, meaning less or no out-of-pocket costs on certain procedures, co-pays, co-insurance, etc. They're really focused on really driving down the total cost of care, what employer groups pay, what patients pay, and even to the provider, they're talking about a 7 to 21 day turnaround time on reimbursement. And by the way, they guarantee the payment for certain procedures on the patient's coinsurance. That means for the provider, they're not chasing collections, they're not calling, they're not mailing, they're not texting, they're not having any collection companies involved. We cover a wide range of things on how the current PBM stack, the management, and the insurance structure are really playing a game, how the Affordable Care Act really didn't do much but inflate care and drive profit into some of the bigger payers of the system. Funny note, he also was a college football coach for University of Colorado State, and some synergies there. So thank you guys for tuning in. Hope you enjoy episode 9. Here we go. Mr. Patton.
Ben.
How are you, sir?
Doing really well, thanks. It's a pleasure to meet you.
Fantastic that you're able to come up here. We met at our June's Better Human Conference.
Yeah, which was really interesting.
Yeah. How was that for you?
It was good.
Yeah.
It was good. Made a couple good connections.
How'd you get connected there?
Had a friend who works at a company called Opt Health, and he invited us.
Okay.
So it was pretty cool.
Was that the group that was passing out the?
Mm-hmm. Yeah, they do kind of like some
B12
medical
shots,
wellness stuff, and I met him at a different healthcare conference.
That's
He's
awesome.
like, "Oh, you should come check out this event." So,
Yeah.
It was good.
Fantastic. Well, tell me a little bit more about yourself, man. How I know we're going to talk a little bit about the company, and you can tell us about that. But give me a little rundown of your history, where you're from, what you've been up to.
I was born in Oklahoma, but raised in the suburbs of Denver. Lived in Indiana until I was 8. But I was a college football coach initially.
Okay.
So I coached at Colorado State in Fort Collins, Colorado. I was a graduate assistant coach there, actually, while I was an undergraduate coach. So
No way.
I coached with some people who are in the news these days. Clint
awesome.
Kubiak, who's the head coach of the Vegas Raiders, was a safety at Colorado State when I was, GA over DBs coaching safety. So I know Clint pretty well.
Okay.
So it's kind of cool to see people like that advancing. And, coached ball in college up until 2012.
Okay.
And that actually is what led me into healthcare.
No way.
Yeah.
Did you play college ball too?
I know. I actually basically showed up as an 18-year-old
Okay.
and was like an unpaid coach, and then I became quality control, then I became a GA. So I basically just jumped in 2 feet forward straight into coaching. I could have played and walked on at some small D2 schools in Colorado, but
Sure.
I didn't really want to go to school at those places.
For sure. That's so funny. Well, walk me across the bridge of how coaching actually led you into healthcare.
Yeah, so in between coaching jobs in 2012, my mom is a primary care family practice doc in Colorado.
Okay.
And coaching job expired on me, like the head coach quit in March, which is really bad in football coaching because no jobs show up again until December. So you're basically SOL until the next year. So you got to figure out something to do.
Right.
And so I wound up working at my mom's primary care office. I got a high school coaching job.
Okay.
Obviously needed to be in Denver because coaching in Colorado, I knew all the high school coaches in Colorado. So it wasn't very hard to get a high school coaching job. And actually it was cool that year. We actually coached against De La Salle with the old head coach and played him up there, which was very cool. Also coached against Christian McCaffrey that year, which was also pretty cool.
How'd the De La Salle game go?
We lost, but it was a really close one. We were very talented that year, but had no depth. And we did beat Christian McCaffrey too.
Where was he at?
He was at Valor Christian High School in Colorado.
Gotcha. Okay.
And then they had a Division I quarterback, a kid named Luke Del Rio. And that was a good coaching performance. We held him to less than 50 total yards.
No kidding.
Which no one in college ever did. Shout out to the punter for the Chargers. His name is J.K. Scott. We had him and a couple other Division I football players on our defense. And I think everybody on the defense either played D1 or D2 football or other college sports.
Wow.
Like a couple of our safeties played D1 lacrosse.
No kidding.
So we
Some
were
athletes.
Yeah, but we had no depth. So then a bunch of the guys got hurt and then we didn't actually finish the year that strong. But we were really good at the beginning of the season.
Well, I might have to consult you. I'm coaching my son's 13U team this fall, so.
I can assist. I still know a lot of guys in the business. So
That's cool. Right on. Okay, so started working for your mom's primary care business, doing a little coaching on the side. What were you doing at the primary care business, and how did that then, walk the path to where you're at now?
What wasn't I doing at the primary care? I think I got in and they just were like, hey, the billing lady's having a baby, so you're going to do medical billing.
Yes.
And so I did that. Then I did everything, helped administer the practice, helped, did referrals, prior authorizations. They had new regs that came out from the Affordable Care Act around MA plans and specialty medications, so the prior auth regs changed on that. So I had to figure out how to get those people on those plans their specialty meds. So all of that was actually really spectacular experience and has informed everything that I've learned at Excel Health Plans, because I got to see so many components of the healthcare system in action. How do we interact with all the specialty practices? How do we deal with the specialty medications? And I even worked occasionally as an MA. So we had an MA quit a couple times, and the main doc would be like, Mike, you're going to be my MA today. And actually, she handed me a blood draw thing on like the first day. I was like, take this person's blood. I just looked at it. I'm like, no.
Good for you.
You want me to chart? You want me to give people's height, weight? My mom had taught me a while ago how to do blood pressure.
Sure.
I can do all that. Needles and administering needles, no.
Well,
I don't know how to do that.
You're painting the picture that's all too real for pretty much every long-standing primary care practice since the dawn of time, right? Which is family members are the backbone of the operations, generally speaking. And you're kind of thrown into the fire. As you said, you really get the benefit of all the experience that you receive from that, and then now can kind of take that forward. So continue. You worked at the primary care office. You pretty much got operational experience in every avenue. What came next?
So really the thing that inspired me to do what I'm doing now is someone had a pacemaker. I would help people with EOBs, because obviously they're like a foreign language to most people.
Sure.
And so upon assisting one of the members with their EOBs, I realized that he had a pacemaker put in, and I was literally adding it up with one of those old calculators that had the like rolling tapes on them. You'll remember, Ben, but some of the younger folks out there won't even know what we're talking about. And the total paid claim on it was almost $700,000 for a pacemaker. And it was because of a medical error. He had to have the pacemaker reattached because it started falling off. And then he caught an infection and was inpatient for weeks. Thus, the hospital in Colorado that he had it at got paid almost almost $700,000.
Sure.
My mom, when she was in residency, we had au pairs from Europe who both work in the healthcare system in Sweden and Switzerland.
Okay.
I called them and was like, this is what happened. How much would this cost in your country? Now, this is way back in 2012.
Of course.
But it was $12K and $15K, and they would warranty the thing. So they're like, well, if we made the error, we would never charge you a cent after that because that would be our fault.
Sure.
And I was like, huh.
Interesting.
How on earth is this possible that, 60 to 70x, depending on the two markup?
Yeah.
How can any product or service in the world have that high of a price differentiation? That shouldn't even be possible. So that really is what inspired me, and even doing things like collections at the practice and seeing how much the healthcare inflation way back in 2012, which it's probably 1.5 to almost 2x. It's more than doubled. It's somewhere between doubled and tripled since 2012. How much it was harming people even then. And then obviously being a benefits consultant, seeing how much tax it's taking on membership, it's definitely a huge problem for employers, and then really even more for their employees, because the employers are now having to shift that cost burden onto to families and having to have them take on more of the burden.
So you noticed early on, one, just the huge price gouge that happens with hospital billings, compared that to other countries who have a different approach to it, right? More of a nationalized, lower fee schedule, and also sounds like take some fault or credibility in the process and the procedures that are happening, that if there is fault, we're not passing that down to the patient, we're going to eat that cost, whatever that may be. And also noticed on the collection side that, hey man, people are really struggling to pay these bills. And that's at the primary care level where for the most part, unless they're uninsured, they're paying their copay, maybe they're paying their co-insurance if they have, or their deductible, or a combination of those three. And that's probably a couple of $100 as compared to several tens of thousands of dollars, right?
Yeah, and obviously you have people who, like, we did some like basic dermatology procedures. We had an X-ray machine in house, and we had like a phlebotomist in house, so we would bill for those types of things. So obviously seeing how some people's insurance plans would cover those things completely, and how some people's insurance plans wouldn't cover those things at all, and seeing how that affected members affected how we at Excel have always constructed these plans. I've been informed on that ever since.
So did Excel come next? You got the operational experience. You start exploring. Your mind starts to, I could just see you calculating.
It took a while to get there. So I think I figured out when I was working at my mom's office the golden rule, which is whoever has the gold makes all the rules.
There you go.
But
that's a good one.
If you think about it, what's happened is the employer market, there's about, depending on what numbers you look at, between 160 and 170 million Americans who get their insurance through employer-based health insurance. And, healthcare costs estimated by Kaiser Family will be north of 5.5 trillion for 2025. And a lion's share of that, well over 3 trillion, probably somewhere between 3.25 and 3.5 trillion of that minimum come from those employer plans. Obviously, Medicare and Medicaid have much more restrictions on what they pay out, so they make up less dollars per person insured by those platforms, certainly, than the commercial basis. And plenty of data like the SAGE transparency data certainly supports that that's how things go, and obviously the cost of commercial health plans. But what I realize is that the employers are basically outsourcing all of their authority over pricing, because at the end of the day, them and their employees collectively are writing the checks for this. They're hiring the carriers and basically taking all their responsibility and say, hey, you just handle this for us.
Right.
And that's what I realized, because so much of what we did at the primary care clinic was just taking care of all the rules placed on us by the insurance carriers and by our billing arrangement with then a hospital system that not very long after that got purchased by HCA. But we were part of a coalition of PCPs who could, work together to bill. So that's what I realized is most of what created all the rules for us in the office was those insurance plans.
Absolutely, 100%.
So I was quite certain that the only way to fix the problem was to really become one of those solutions. But I obviously at that point had no idea what or how that needed to look. So that was really the journey, was to go, all right, how do I even start to figure out what a solution to this problem would look like? And so, yeah.
Kudos to you. I obviously I work in healthcare, right? I've worked in healthcare for 20 years. My grandfather was an orthopedic surgeon. My grandmother was a nurse, trained. She stayed at home wife. My uncle, orthopedic surgeon. My mom was a nurse. I went to, I did my undergrad at the University of Nevada in Reno. At J. Norvell, not probably during your time, but left to go to Colorado State a couple years back.
We actually coached against Cap when I was there. We played him twice when I was there. Once we beat him, and then the second time he absolutely destroyed us. So.
Yeah, well, I mean, I would imagine the second time they also had Vital and Luke Lippincott, and they had kind of the
Virgil Green, actually.
Virgil Green, all of them. I mean, you think about it, you got a great tight end, you have two great running backs. That year, all three, Kaepernick, Vitala, and Luke Lippincott rushed for over 1,000 yards. Yeah, and then you have Virgil Green, and we had some pretty good receivers too.
We played them in 2010, and they must have beat us I know they hung north of 50 on us. I'd have to go look at that.
It's the best Nevada offense that they've ever had.
Yeah, they smoked us.
Yeah.
I think you guys smoked Cal right after that too.
Smoked Cal. I mean, it was a great time to be a Nevada fan. Probably the apex of fanhood at that point in time. And then then the conferences changed and everything else. But going back to the discussion, I've worked in healthcare my entire life, right? Since I've been here, kind of the same thing. When I've been here in the Bay Area, I've worked in behavioral health, primary care, pediatrics. I've done ACOs, value-based structures, shared savings, managed care. I work for independent physicians now in the IPA structure, so we're a part of that coalition. We call it an IPA in California.
Yeah. Yep.
Bring the contracts together, go do collective bargaining and everything else. And one of the things that you hit on that I think not a lot of people recognize is those who have the gold makes the rules. We are all beckoning to the insurance companies, right? We're all trying to follow those rules. Yet they get tighter and harder, and the navigation becomes a little bit more tricky. So walk me now through, you've got the experience in primary care office, you're starting to put some pieces together, you want to create a solution, and where I was going with it is kudos to you because there's a lot of complaints. We spend $5 trillion on healthcare, 5.5 probably in 2025, it's gonna go up in 2026. A lot of people are knocking the stack. The insurance companies, the PBM, the management arm, all three of those combined. Rightfully so. Not a lot of solutions being thrown out at it, right? So you think, I got to get into this, I got to become a part of it, but as a solution. Tell me about that approach.
Yeah, well, I mean, obviously, I think that, I just saw a market opportunity and felt like it was needed. And I think I'm driven mostly by my faith to do that. But also, so I started working as a benefits consultant, got a job actually through a guy who was a booster from Colorado State. But I had been interviewing at quite a few other firms to really just start to get my hands dirty with what's that. I actually tried to be an analyst for the brokerage firms first to see the money move, but they wouldn't hire a marketing major who would only coach football to be an analyst in 2014. 2014 was a little bit of a tough job market, so that wasn't happening then. But so I got a job as a broker and just started selling plans. And what I realized as a broker was I started to understand the needs of the employer, but also understood that there's a lot of conflicts of interest. And I ran into the bonus program. So the carriers will actually pay the brokers highly lucrative bonuses to do things. And it was a little bit of a scuffle, which affected my status at the firm. I didn't leave over it. I left about 6 months later, but yeah, there was certainly some pressure that I created around bumping up against our firm's relationship with Cigna and how much Cigna financially incentivized us to keep and retain business with Cigna. And, if you look at the Marshes, the Aons, those types of companies nationally, on their benefits book of business, which I will say is a significant minority of their book. Most of those companies are property insurance firms first. It's probably 70-30-ish revenue-wise, property insurance to benefits, but about 25 to 30% of their total benefits comp comes from override bonuses from the carriers. Now, that's not the health carriers exclusively. Some of that is the Guardians, the MetLifes of the world, but the health carriers certainly provide significant incentives for the brokers to maintain the model as is. And I don't think employers are aware of those interests of the brokers when they're meeting with their agent from Marsh. Now, also on the other side, not to blame the brokers either, there's not a lot of differentiation between the product offering. And that's why I think a lot of HR directors, CFOs are very cynical about this because if they've been an HR director or CFO for a while, they've met with someone from Marsh, from Lockton, from Aon, from Gallagher, blah, 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 blah. And they basically feel like if I go get an RFP from the four of them, they're going to give me effectively the same thing that's priced within, 5 to 10% max. Maybe Kaiser has a different price point or a Geisinger, an Ashley, or an HMO. But other than that, it looks pretty much the same. And I can get, if I'm currently, if I'm Apple and I'm with Aetna and I get a 5% lower RFP from United, I can go back to Aetna. Aetna will find some way to make less money on the PBM or whatever, and they'll match the net price. And, for Apple, it's like, what's the point of dealing with switching if I can get the same price? And that's basically what happens. So, from a market standpoint, a true market standpoint, there's a lack of product, which aligns what the client, the employer and their members are looking for. And part of that, is it the carrier's fault? However you want to define that. But certainly the incentives from the market strategy and the Affordable Care Act provide incentives for the employers to maintain the same because their profit margins are capitated by the ACA. So, the way the ACA is written, the total profit margin for United, Cigna, Aetna is capped at like 20%. And so the problem is they have an incentive for the pie to be bigger. And if United or Blue Shield of California goes to Sutter here, because we're in the Bay Area, and says, hey, Sutter, we were paying you $30,000. This is, 2011-12 for this procedure. How about we pay you $50,000 for this procedure now? You'd be shocked to know that Sutter's like, cool.
Oh yeah,
Great
very,
idea.
very shocked, very shocked, right?
Yeah, they're like,
Yeah.
this is great.
So what you're saying is, let me stop for a second. So what you're saying is, to retain business and to increase margin or maintain the 20% margin that the ACA, the Affordable Care Act, puts on, the plans that were in the exchange, they can go, the insurers can go to the provider.
And that's not just exchange plans; it's all fully insured plans of any kind.
But they go to the employer and say, hey, we'll actually give you an increase for said procedure, just so they're able to basically offset loss but keep margin.
Correct. Right? And it increases the margin making opportunity for the carrier as well. So they obviously did that for a while, and obviously they have to have done that, right? Because the cost of health insurance has more than doubled.
Is that public?
Yeah.
Are there papers on it? Is there?
Yeah. So the primary data source we use for that and all of our stuff or fundraising material is the Kaiser Family Foundation is the best source of that data. Sure. So I'm happy to share all that stuff.
No, it's interesting to explore a little bit deeper, because I think the minutia of what actually happens on the financing side of things, the average consumer and even the average employer, because most small employer groups, they're likewise, they go to their broker and they're like, hey, I got primary care office. I might have 8 people,
right?
That I now have to offer insurance for in certain states. And what do I get for it, right? And they go, well, if they want a PPO, it's going to cost. If you want an EPO, it's going to cost. High deductibles. If you want the HMO, if you're in a Kaiser market, by far going to be the cheapest. Maybe there's some other options, right? Geising or others across the country. And they go, oof, and that price tag on it's steep, right? But as we start to think, like, why is the price tag so steep? Well, it's really the optics of how these big insurance plans are treating the market as opposed to what the market demand is.
Correct.
Right?
Well, and if you think about it from the carrier standpoint, right, post the ERISA passage in the late 70s, they've been and the ERISA passage for everybody out there had a big effect on Medicaid, and that's when Medicaid was created. So with Medicaid and Medicare, the hospitals started to claim in the 80s, oh, well, we're losing money on these two products, which at least according to like the SAGE and the RAND data says that that's true from the reported stuff on hospitals, that they can't financially exist in the current model. I mean, we can have another whole conversation about, is our model way less efficient than any other Western system, which it is, but that's like, they can't make money on that currently. So then they said, okay, well, we need to pass the losses off to increase commercial insurance rates. Right. And they started doing that in the 80s. And they've basically learned over the last 40 plus years that they can pass those increases off to commercial plans, and the commercial plans will accept those increases.
Right.
And that's happened from, my uncle was telling me a story that he was actually here in the Bay Area working for a oil and gas like remedial company called Exeltech. And he was like, yeah, back in 1988, we had insurance rates of $90 a person a month. And now I'm looking at, for last calendar year, the rates on individuals being $1,200 a person a month. Yeah. So obviously an order of magnitude different in 35 years. Right. And much steeper than actual inflation over that period of time by probably a factor of 4. Right. So yeah, that trend has continued because I suppose for the carriers, it's always been true. So what's to stop us from continuing to do what we've always done? And I think that's, from the simplest point of view, how these guys operate. Like, this is how it's always been done. Right. What's the point in changing? Because the getting's good. I mean, if you look at the stock price of Cigna, Aetna, United, Anthem, I mean, their still net stock price post ACA has exploded. Their valuations have gone from Fortune 50 to 100, maybe even a little outside the top 100, to all 4 of them are inside the Fortune 20, at least in the US. So, these guys have massive evaluations. CVS and United have been at their peaks as high as Fortunes like 3 and 4. Right. You're talking bigger than a few of the giant tech firms around here. So
yeah, what's interesting within that, and I want to get more into Excel and I want to hear your solution, but what's interesting within that space is, if you think about what the Affordable Care Act did, forced people to get insurance. The government backed the insurers, increased prices, so inflation automatically went through the roof. Yep. Right? the mindset to the public is, oh, great, everybody should have coverage. The government's going to help subsidize that coverage so people get access.
Yep.
But what they don't realize is that what it really did was guaranteed financial solvency for these plans. And I don't mean just solvency, but profit, right? By allowing them to be, on one end, subsidize the cost by the government and increase prices, right? And so it's almost like the same people that complain about the profiteering that happens within the big insurers, the PBMs, the stack, are not understanding that, yeah, I'm pushing for the government to pay these private companies to insure everybody, but it's also inflating the valuation, as you said, over the last 30 years of these companies to go from Fortune 5, 100 to top 20, right? So it's like the same coin, but we're pushing it in the same direction.
Correct.
Right? So tell me a little bit more about Excel. What's your solution? What do you guys do? How is it different? Who's your target? Your growth strategy? Talk to me about it.
So really became a benefits broker, and I spun off out of that other organization into my own shop to just give myself the freedom to do whatever I needed to do. Sure. Always with, we needed to build a plan in mind. But I view it as, I'm trying to build the Keebler factory, but I need to start a bakery because I don't know what the recipe for the cookies needs to look like. I don't know what's going to sell. So really became a spin-off benefits consultant to learn what does the model need to look like that I thought was most scalable. And what we landed on was a model that's a PPO plan, because if you look at nationally, according to Kaiser, about 90% of all commercial lives in the US are on PPO plans. So, and Kaiser actually makes up like 7 of the last 10% of commercial people on HMOs. Like most of those are with Kaiser, and most of the rest are in markets like Southern California, Miami, Pittsburgh has like the UPMC, and Boston and Philly. So, you know, in most markets in the US, like commercial HMO utilization, like I'm from Denver, so like non-Kaiser commercial HMO utilization is basically zero.
Yeah.
So
I mean, if you think about it, even if you use the Bay Area as a proxy,
Bayer is like that too.
Well, I know, but I'm saying if you use it as a proxy, if you work for a tech company, you're not going to go with Kaiser.
Right.
You're going to go with the PPO.
Right.
If you're employed through a union, police, fire, any of the subcontracting, plumbing, fitting, electrical, elevator, all that kind of stuff, you're probably going to go with Kaiser, right? You're not going to. It's very rare that you're going to be one of these, you know, white collar, if you will, higher salary employee group that goes with an HMO that's Kaiser or even non-Kaiser, right?
Yeah, and what I would say, and they obviously lived in LA for a while here, in Colorado, I would say like you get a people here who like have just like a palate for Kaiser is how I would describe it, where they're just used to it and they just want Kaiser. But I think independent of that, when we crafted the solution, we just wanted it to be PPO because the carriers have done a good job marketing when the PPOs were created in the 90s, that in order for your benefits to be good, you basically have to have access to effectively every provider in the market. And if you don't have that, you know, the perception from the employee is I have inferior health insurance if I don't have access to every single provider.
Right.
So that's the sales challenge of delivering a plan that operates different. Is those are the parameters in which you really just have to compete. Is if you can't, if you walk in, if a benefits broker walks into an HR director or CFO and says, I'm going to offer you a plan, the first conversation is, inside the C-suite, is any doctor that any family member in there see covered by that plan? And if that answer is no, it's almost a non-starter to can we entertain that plan?
Sure.
So if you don't cover those bases, you can't do that. So that's the base point of our plans, but we typically use the non-carrier based rental networks, just like a credit card network. You can rent Cigna, Aetna, United, even depending on who you are, Blue Cross, some of the Blue Cross's networks. But there's a lot of strings attached with those. So we historically don't do that. I mean, maybe in the future we might have a partnership with one of them, but historically we don't do that. And the reason for that is because they put some handcuffs on you. So what I learned when I was at my mom's office is like how Medicare Advantage based HMO plans function. And they they really control the members' behavior very firmly because the carriers go at risk on them a lot. Like if I'm United Healthcare and I have a person, maybe the federal government's paying me, depending on the market, $2,500 to $3,500 a month, but that person could be anywhere between 65 and 100 years old. And 100-year-old people can wind up spending a month in the hospital for a light cold that wouldn't have any effect on you and I.
Right.
So they have a much higher incentive.
Right.
So it might sound like a lot of money, but that person is also way higher risk than us.
Correct.
So they have to manage that person in a way that reduces the odds of catastrophic loss on that person.
Right.
So they have different techniques in managing those people, really 180 degrees different from the way they manage people
100%.
on the commercial side.
100%.
They have no incentive to drive costs down on the commercial side. So they don't. They really just follow the incentives. They're not I view them as like they're just going to do whatever the marketplace has incentivized them to do, and they're very good at it.
That's right.
But because of that, they put things into their commercial PPO contracts like no audit provisions. So if a claim comes in and there's a $3.5 million premature baby on a Cigna or United Rental Network, under no circumstances am I allowed to audit that claim under any circumstances. I can't request any information about the bill. So for the privilege of accessing their network, I can't ask for anything.
Right.
Now, I think at some point in the future here, there's already litigation in place which will rule the plans as ERISA plans, which is any employer north of 100 or partially self-funded employer in the U.S., as fiduciaries for those plans. Sure. And there's no way you could ever defend yourself as a fiduciary saying, I signed a contract with Cigna, Aetna, United with no audit provisions on the network arrangement.
Right.
But that's how they are. So we don't use them because we don't want to be handcuffed by those provisions.
Well, let's walk back to the beginning. Walk me through the basics of what Excel is and does.
Yeah.
Are you guys a health plan?
Yeah, so we're a health plan. We're a partially self-funded health plan, which Cigna...
What does that mean? Tell us a little more about that.
Yeah, so partially self-funded just means that like a gigantic company like an Apple or a Walmart is so large that they have no insurance policy in place. They just hire an Aetna, a Blue Cross to be their administrator and to provide pharmacy benefits for them. But if you think about it, Apple has 100,000 employees in the U.S. Walmart has a couple million employees in the U.S. on their health plan. And to be an insurance company in the state of California, you only have to have $11 million in cash reserves. Well, these companies are spending $3 and $25 billion a year on health insurance for all their employees. So obviously they're insurance companies in order of magnitude over. So all a partially self-funded plan is you buy a reinsurance policy from companies like Voya, Sun Life, Tokyo Marine, companies like that, and they will create an effective self-funding. So you have a fully insured equivalent rate, which caps your price at $900 an employee a month, $1,500 for employee plus spouse, $1,200 for employee plus children, and $2,400 for employee plus family a month. And that insurance policy takes the risk between, the gap up to infinity for you, and you can build that on the back end. So that's effectively what our plans do, is we build those types of plans. But much more importantly to the employer, we build them in such a way to make sure that they can get much higher value and much lower cost to the members.
How so?
And the way that we do that is we guide members to higher quality, low cost locations. So for instance, here in the Bay Area, if you go to Sutter in Menlo Park, just not very far from where we are right now, they will charge between $180,000 and $220,000 on a PPO plan for a total joint replacement, which is
that a surgery center?
No, that's inpatient in the hospital.
There's a hospital in Menlo Park for Sutter?
Yeah, I think so.
St. Carl, Mills Peninsula, Burlingame?
Yeah.
Yeah, okay.
Yeah, that one. They'll charge anywhere in those price ranges. And that's pretty consistent for Sutter in the Bay Area in general. And Sutter is one of the higher price systems in the U.S. They are right at the top. Not the highest, but close. And if you go to Mountain View, California, you can go to the outpatient surgery center down there, and Stanford Ortho actually practices down there. You can get a total joint replacement for $22,000. and they actually make more money because the surgeons own a piece of the center, and what we do as Excel is, if you're willing to go to the outpatient orthopedic center, we'll waive all your out-of-pocket costs. And through some of our data vendors, we actually measure the quality outcomes of the providers, which typically the PPO networks actually don't allow. On the commercial side, they won't tell you anything about the quality of the providers. So we'll say only the providers with an A rating, you can go have your surgery, and we'll waive all the members' cost share. No deductible, no co-insurance, and we'll even provide medical transportation.
And so you guys, let me back up a little bit. So you're a partially self-funded plan, which means you also have another plan that helps guarantee some of the back end, right?
Exactly.
You guys go out, build the network.
Yep.
Maybe in the future we'll partner, rent some type of network if it works for you guys, meaning you may go to another insurer and say, hey, we'll partner on some things to get access. But for now, you're going out and doing direct contracts with providers and facilities to build the network.
And there's a lot of vendors out there who help us provide these contracts. So there's a lot of, they're called point solutions that typically work with ultra large self-insured employer plans. And so we partner with them, and a lot of them have national based agreements for these things. So for basically anything that isn't inpatient in the hospital, things like lab work, we have a national partnership with Quest. Things like imaging, so we have multiple national partnerships, so you can go to pretty much most of the outpatient imaging centers here in the Bay Area. We have a direct agreement with, where you can get an MRI for $300 to $500 instead of $3,000. And then things like renal failure, diabetes, both the testing strips and the insulin, even things like cancer care and dialysis. Exactly. We can get all of those for somewhere between 50 and 90% discounts versus what PPOs pay. And we pay.
How is that? If it's the same network as a lot of these other companies?
Well, it's not. These are like direct cash pay relationships. So I'm sure a lot of people out there have experienced, like, if you go in there and you say you'll pay cash and you'll pay them right then, a lot of the providers will discount things drastically. And that's effectively how these arrangements work. So really what happens is we're paying these people direct rather than paying them on the PPO network. And thus, you know, we have a direct relationship.
How does that differ if you're a provider? So go back to your mom, right? You go out to an office similar to your mom and say, hey, we're Excel. We are a new health insurance solution. We pay you direct. If you're back in your mom's office, you're going to say, okay, well, I got 17 other payers. They directly pay me, right? And maybe there's a contract layer in between, but somebody's giving you the cash. How does the claim process differ for the provider or the facility as opposed to going through one of the bigs?
Well, it is much more direct. So typically in these, when they're dealing with insurance carriers, they're dealing with a significant lag, anywhere between 60 to 120 days when dealing with the payers. So that layer disappears. Most of these agreements with most of these parties, we have a much shorter time window to pay them, anywhere between 7 to 25 days, depending on the arrangements.
When you receive the claim?
So we have to pay them much faster than that.
And does that help get you a better discount by saying, hey, we'll pay you faster?
I mean, time value of money. The providers waste a lot of time. And then the other thing that's huge to the providers is what we call the disappearing deductible for this, which is the waiving of these members' cost sharing, because the providers waste a lot of money dealing with collections on these members. My brother used to work for the, I can't remember. It's the University of Minnesota hospital system. He worked for a law firm that did like collections and that type of stuff and contracting for them. And they would only recover about 30% of the total members' cost share on all plans corporate wide. So that means they're literally writing off 60% of the alleged member stuff. And who knows how much of the 35 to 40% that they're getting, they're having to pay to people like this law firm or collections agencies. And that's why a lot of hospitals have to bring it in-house. So if you think about that loss too, when we tell them, hey, you never have to do any collections on this either, because we waive the members' cost sharing immediately for you. Oh, then they're like, oh, even better, we don't have to deal with that.
So on the front end, you go to an employer and say, hey, we can give you
vis-a-vis a broker. We always distribute through benefits consultants.
Of course. So benefit consultant goes out to the employer and says, hey, here's some RFPs, right? Here's some different solution options. Excel is X%, What would you say?
Usually 20% minimum.
We got an
below.
option that's 20% lower than your standard, right? And it's a PPO.
Correct.
The employer says, really? How does that happen? They say, you know what? If we can drive your network to go to lower cost solutions, outpatient procedures for the most part, right? Outpatient, whatever, labs, procedures, et cetera, we can reduce the cost. And by the way, to your employees, if they do that, this Excel PPO option is going to pick up any co-insurance or cost share that they have, as opposed to going to the big systems where the costs are heavily inflated. They go, okay, that's great. So they sign a contract with you. You then go back to the doctor and say, hey, we got this new network of patients that are going to start coming your way. Here's, obviously the member card is going to go to the member. They show up, they're contracted with you, they can see you. Can you now, as the insurer, do you have the right to deny the claim for medical necessity, documentation, coding, all of that kind of stuff? Or you guys say, hey, we're not doing that. If they show up and they see you, we're getting you 7 to 21 days of payment. How does that part work for you?
Yeah, so obviously with anyone who's in those direct relationships, and we've also simplified that. We tried to make our plan document, which is the governing policy for everyone out there that determines how everything is paid, exponentially simpler than is normal. I will say, like, if you guys take a community rated, like United or Blue Shield of California plan from here, their plan docs are crazy opaque. You would read it and you would feel like, all right, everything in here is covered, but it seems like they have wiggle room to not pay almost any of these claims.
That's right.
So our plan document doesn't function that way at all.
Okay.
We try to make it extraordinarily simple on purpose, where we have a gigantic grid in there. Like, it's literally a grid when you download the thing, and it has the procedure names, and then it states exactly how it's covered.
Okay.
And that's how we want it. We don't want the member or the company or the broker to have any confusion about what is or is not covered. And we honor that plan document as is written. We force the stop loss carriers to sign what's called a mirroring provision. So they are required to mirror that plan document. We make their lead underwriter sign off on it before we even start a contract with them. Now, unfortunately, I had to learn that one the hard way. And that's how we do it to enforce that. So that way, for all parties involved, including that provider, it's extraordinarily simple. This thing is covered. It's covered 100%. There's no question about it. You're going to get paid. Don't even worry about it. And we, pay them fast and on time. And that's key for all these arrangements, is the providers have to feel like you're a partner, like they can count on you. So that's certainly a big portion of it. But in the end, that can create net plan savings because there's a lot of unnecessary inflation that goes on with the utilization of care through these PPO networks at the hospital systems.
So you're saying to the employer through a broker, we can get you a 20% discount. You're telling the provider, not only are we going to get you reimbursed fast, but we're also going to cover the members out of pocket. So you're not going to have to chase the cost share that they have, which, as you said, in some instances could be a write-off of up to 60%, right? You're not going to have staff spending time calling them. You're not going to have your EMR, your text-based system, mail, anything reminding them that, hey, you're 30 days, 60 days, 90 days delinquent is going to go to collections, and now you're paying a collections agency X% on the dollar, right? We're avoiding all that administrative hassle. We're avoiding all that cost. We're giving it directly to you. Okay. Now, tell me about your hospital contracting strategy. Are you contracting, renting contracts?
We're just renting contracts right now. So typically we use, as I discussed, actually some of them are carrier owned, like Aetna and United. Their contracts called like First Health, or one's called Health Smart here in California that we typically use. And Health Smart is a TPA that UHC bought. But I mean, a lot of these contracts are actually, and part of the reason that we do it is because of the flexibility that they have. Health Smart and First Health are negotiated similarly with Aetna and United, but they get significantly less discount off billed, but they also come with a lot more flexibility contractually. And the reason they come with so much more flexibility contractually is because their primary purchasers of these networks are actually the workers' comp carriers. And workers' comp is just a totally different beast. And if they put some of the provisions that are in the carrier contracts that they put to employers and third-party administrators, like the work comp carriers would be like, they would be done before they even started. Workers' comp is as I'm sure everybody is aware, they're very meticulous on how they manage those members, and they're not going to allow for anything else. So by working with those networks in that fashion, we're able to gain some of those advantages that workers' comp has. Even though we get a little bit less of a discount off of billed charges, the ability to review the bills, do payment integrity audits, that type of thing is still lowers our unit cost. And our plans on over 350,000 member months, that's one member on the plan 1 month, has been under $10,000 per employee per year. So total health spend, including administration and employee out of pocket, divided by the number of employees, versus the national average for this year is 18,500. So we come in drastically lower on our total cost, as well as the losses on our risk are much lower because we provide what we describe as aligned incentives between the member and the health plan itself, which obviously a combination of the member and the employer are paying for.
Of course. Why do you think some of the bigger payers aren't taking the same type of strategy where they, hey, let's just direct everything to the lower cost providers? I'd imagine all the bigs that we've talked about have direct contracts with Quest, LabCorp, the radiology centers, all of X, Y, and Z. Why do you think that they don't take that same approach and shift away from some of these big institutions?
Well, I think the kicker is that they don't really have any incentive to. Right now, I mean, the total cost of care being higher is good for them. And what I think you've seen, let's pick on United as an example. They're obviously the largest carrier in the U.S. With the 80-20 split in like the medical loss ratio, we've seen United kind of probably max out the margin that they make in their 20%. So now what they've done is, how can I start to gain some of the revenue in the 80%? And that's where a lot of the pharmacy benefit management comes in. And I can send you some detail on the breakdown of how much of a drug cost goes to the other parties in the supply chain. But between the pharmacy itself, the insurance carrier's cut of the spread, and the pharmacy benefit manager's cut of the spread, oftentimes they're making nearly as much, if not slightly more, than the manufacturer themselves is. So that, and think about that, that's always coming out of the 80% of the claims.
Right.
So there's a way for United to capture revenue. Now, United is also the largest employer of providers. So if they're referring you to an Optum provider, now they're gaining that revenue that's being paid out of the 80%.
So they also get not only the revenue from the premium of the insurance product.
Correct.
And they have a medical loss ratio 80-20,
Yep.
right? Which in Medicare Advantage 15%.
Yep,
so
15.
that'd be one way to regulate it. But they can also potentially offset the utilization of the PBM as an expense, right? Which is where a lot of people are upset. They say, hey, if you have this in-house organization and the cost structure is super high and unregulated, if you will, and there's no MLR currently on the PBM side,
Correct.
you can inflate the cost, which now allows you to, once again, increase your MLR, right? So your 20% of profit can keep going up as long as the PBM expense is going up.
Correct.
Right? Which a lot of people are, hey, that's not
and then
cool.
they buy the providers, hike up the provider's expense.
Absolutely.
That inflates everything,
Right.
but it also increases EBITDA for the big
100%.
carriers,
Yeah.
which, I mean,
And the cycle repeats.
it is, and it's hard, and you do have to have, and I know people out there, it's hard to have empathy for like executives at health insurance carriers, but these people in publicly traded companies, they have a fiduciary duty to the shareholders,
Right.
to where they can be held personally liable and go to jail for not looking out for the best interest of the stockers. And I think the unfortunate thing about the health insurance market is that in other markets, it's really competition that holds down the price.
Exactly.
But in healthcare, really the four of them, and in my kind of sector of the space, we kind of call them the BUCAs because they all kind of operate the same.
Sure.
Blue Cross, United, Cigna, Aetna. They kind of act the same. So they don't really, none of them are interested in altering the business model to try to gain market share.
Right.
So because of that, there's effectively not any competition because none of them have changed their business model.
It's not a free market, right?
No.
There's no true competition. And you're right. One thing that I hear all the time, and it could be from executives, it could be from people within the industry, it could be from doctors. A lot of it's from patients. So, the healthcare system in the United States is broken. I said, no, it's not. It's not broken at all. It's doing exactly what it was designed to do. It's incentivized, right? All of the incentive is to maximize profit at every single level of the game. It's not intended to create outcomes that are health derived by prevention because there's no profit. Pharmacy doesn't make money if patients aren't getting the pharmaceuticals. The pharmaceutical drug companies don't make money if patients are healthy and don't need it,
Yep.
right? Hospitals don't get paid. Insurers, if all of a sudden supply and demand shifted and people didn't need health insurance because they're like, you know what, I'm not going to pay 20 grand a year in premium if I never use it because I'm healthy. Now all of a sudden that goes down, right? I mean, the system is designed to profit off of the end user. But let's shift one, before we wrap up, I'd love to hear a little bit more. What's your strategy now? You've kind of got the solution. You have a discount that you can take to the employers. You have a strategy that you can take to the patient, right? And the provider. So you have kind of that integrated network where you can go, hey, we have a solution for you. Now talk to me about your growth strategy. How do you guys plan to expand and what's that avenue look like?
Yeah, so right now we're building out our sales team and looking to scale much more broadly in a number of states. And part of what we're doing as part of that strategy is building some underwriting tools, because what the carriers have done in the last really 2 years is develop the ability to create RFPs with no data on them. So like in healthcare, in property insurance, it would be totally not frowned upon, like illegal for a property insurance carrier to not give you what's called a loss run. So any losses you've had against any form of property insurance policy, some of these are stored by like a LexisNexis database, and they're required by law to provide, and this is like all 50 states, doesn't matter what state.
Sure.
In healthcare, it can be, other than a couple states like Nevada and Texas and a few others, it can be extremely difficult to actually get all the claims that have incurred against your plan, especially on companies with less than 500 employees. And so, and obviously that's not done on accident. So in order to move companies to this strategy, most of the time, those reinsurance companies that we talked about, the stop loss carriers, they require data on this. But now the partially self-funded plans of Cigna, Aetna, and United, and now Anthem as well, can go all the way up to 500 with no data fields other than name, date of birth, zip code, and gender.
Wow.
And they can run you an underwritten RFP in 2 days.
That's crazy.
Without anything. And there are some other companies, trying to innovate and doing some innovation in this space. But the reality is that because of their advantages, as we just described on the pharmacy side, they don't actually have to be as accurate as we do, because, if everybody's seen, there's a cancer drug called Keytruda. It gets advertised on TV all the time. Keytruda is extraordinarily expensive.
Sure.
For, an average adult, it is based mostly on weight. So like, females probably are only 140,000 a year versus larger males can be 250,000 a year.
Sure.
For the same drug. And if you go to a Sutter and get that administered there, most of the cost of that drug is just upcharges kind of being hidden from you between the PBM of the carrier vis-a-vis the network and the hospital. Because like through Excel Health Plans, for even like average adult male, we can buy Keytruda from our specialty pharmacy for about $36K a year. And if we can get you, and here in the Bay Area, there's a number of outpatient oncological infusion centers where we can send you there and they'll accept us mailing that Keytruda to them. And, sometimes we pay them more for the infusion than they would even allow on the PPO plan, because they're not getting any markup off the drug. So we'll pay them $300-400 more.
Yeah.
So we can get that Keytruda administered for like $50,000 a year instead of $200,000 a year. But there's no incentive for the carriers to do that. And on the underwriting basis, the carriers don't really care if they miss on that, because the net result of that is, if you're Aetna, is Aetna paying CVS Caremark $100 grand for that Keytruda. Oh, whoops, we paid ourselves.
Yeah.
Not that big a deal. So they don't have as much of a tone for accuracy. So in order for us to in-house that stop loss risk and be confident in it, we have to build a more accurate underwriting model, which we're partnering with a technology company Dartmouth's data platform and then a data provider from the East Coast who can get us access to really distinct medical data. And we're using AI to craft basically a new underwriting model to be significantly more accurate on being able to get that data up front. And we do think in the long run, it could actually replace any need for the claims data at all.
Wow.
Because the claims data, if there's any turnover in an employer, can be somewhat inaccurate.
Sure.
So that's really our next innovation that we need to finish. And we're confident once that's finished, which our plan is to have it finished by the middle of the summer, to be able to really increase scale for the end of the year volume. Because, our primary target market is these employers with less than 500 employees.
Okay,
Most of them will are at least open to turn over their health insurance. Sadly enough, at this point, every single year.
Yeah.
And I wouldn't say that's, if you talk to the HR director, the CFO, that's not by choice. It's really because the finances have become so tight on it that they don't have
And if you're able to
any
offer
choice.
a 20% discount on it, why wouldn't they? Right?
Exactly.
They should too.
And really the sales pitch to them is, the zero deductible plan. And the only thing is they're using a non-brand name network. And we even have an entire, set of flyers to the employer where it's like, Kirkland soda, you're basically buying the knockoff brand of the network, but you still have the same access to everything you want.
That's awesome.
Yeah.
I got one last question for you. I ask it to all of my guests. It's a healthcare podcast, healthcare focused. You work in healthcare.
Yes, sir.
In your own words, what is healthcare to you?
Ooh, I think healthcare is just part of the economy that is people seeking healthcare. So I think at the macro level, Warren Buffett describes healthcare in the U.S. as the tapeworm of the U.S. economy. So I think the biggest takeaway for everybody in the U.S. is, what is the percentage of GDP that we have devoted to healthcare versus what are all the other countries in the world? And and I think that's the most alarming trend is we were in the low teens, 11 to 12%, 99 to 2000 range. And we're now creeping all the way up to about 20% of GDP. And if you look at all the other Western countries in the world, they're delivering healthcare for an entire 10% of GDP less than us, which is just a net loss to all of us because healthcare doesn't really net any economic activity. It's just something that everybody has to do. And I think probably the most alarming thing of all of that is just the value that our healthcare system provides. Yes, we're still probably the best at the unusual stuff, partially because we're the only country willing to throw so much money at it because there's financial incentives to do so. But other than that, we actually provide particularly poor outcomes compared to a lot of our Western neighbors. In most of the WHO indexes, we're, between high 30s and 50th in terms of overall quality of care provided in the world. And, most Americans would be shocked to know that we're around mostly second world countries, not first world countries in terms of quality outcomes. But yet we pay a price that's so high that we're more than double anyone else in the world. And things like infant mortality, mother mortality, infection rates in hospitals, we're an order of magnitude higher than all of the other, relatively wealthy countries in Asia and Western Europe. Like we're way worse than them. So I would say that's the biggest thing is like the percentage of GDP and then the value we return for it. That's the most alarming thing when it comes to healthcare in the U.S.
Michael Patton, appreciate your time, sir.
Thank you, Ben.
It's been a pleasure. Give him some, dude. My man, football coach.